Hi all, we'll just wait a few more minutes just to get everybody logged on, but we will start here in just a few moments.
Recording in progress.
I don't know.
Okay, so I think we're going to get started. Okay. Okay, so on behalf of the Canadian Hemophilia Society, Alberta chapter, I'd like to start tonight's meeting by welcoming everyone and thank you for joining us for tonight's meeting. I know how busy life can be, so thank you for taking time out of your busy schedules to be here. For those of you that don't know me, my name is Sarah Goodyear, and I am the Administrative Assistant for the Alberta chapter, and I will be your host for this evening. A few housekeeping items before we get started. I'm sure most of you are all pros at Zoom by now, but if you haven't done so already, please mute your phone lines. This helps to reduce the background noise and echoes for everyone on the line. There will be a Q&A at the end of this session. Please use your chat feature to ask your questions. To use the chat feature, click on the chat button at the bottom of your screen. A chat box will appear. After you're done typing, hit enter to send. Feel free to ask your questions at any point during the call. However, it won't be read out till the Q&A portion. If you are disconnected during the call for any reason, please use the same link provided to reconnect. The call will be recorded and available for playback if you should miss anything. So I think most people are online now. So we are very excited to be here talking to you today about the long-awaited approval of Hemlibra. This is a game changer for so many people affected by hemophilia that we are proud to be partnering with the Northern Alberta Pediatric Hematology Clinic to bring you this seminar. So it's with great pleasure that I introduce tonight's speakers, Dr. Dave Stammers, Clinical Director, and Heather Bauman, RN, both of the Northern Alberta Pediatric Hematology Clinic at the Stollery Children's Hospital. And we also have Nikki Gleitcher, who is from the Calgary Pediatric Hematology Clinic. So I will pass it on over to Heather, and she will take it away.
Great. Hi, everybody. I'm so glad, so glad to be here this evening. I just wanted to do another, I know Sarah just introduced Dr. Stammers and Nikki, but I just want you guys to be able to put a face to a name. So Dr. Stammers, if you're able to introduce yourself.
Yeah, for sure. So I'm Dr. Stammers. So I just joined the team in Edmonton 2 months ago, 3 months ago.
July. Yeah,
July, yeah, who's counting? I came from Saskatoon, and yeah, really excited to be a part of the team here in Alberta.
Awesome. Thanks, Dr. Stammers. And Nikki Gleitcher from Calgary.
Hi there, I'm Nikki Gleitcher, and I've been with the Southern Alberta Pediatric Bleeding Disorders Program for about 3 years now. And before that, for a couple decades on and off with the Calgary program and Vancouver before that.
Great. The other person we have joining us today, in addition to Sarah, I don't know if Leanne is here, but Leanne's going to give us a parent perspective at the end. So I'll just have her do her thing when the time comes here. So we'll go to the next slide. Okay, so I really want to emphasize the purpose of tonight is not to convince you guys of anything. Hemlibra is a very different treatment than what we're all used to. So it's really to just give some really basic information to our families and patients. Ultimately, the final decision will be made, from between the families, the patients, and the teams at the hospital. So the information we're giving tonight is geared solely towards pediatric patients, and specific details of kind of the switching logistics. That'll be different between both clinics. I think there will be some similarities. So Nikki and I are both here and can answer those types of questions. So quickly, I just wanted to do a quick history and overview of kind of how we got to this point where Hemlibra is approved. Dr. Stammers is going to go through the mechanism of action, And maybe the side effects, or I can do that. The mode of delivery and schedule of dosing, we're going to have Nikki touch on that point. And treating bleeds, what's next? That will be back to me. And then I'm going to switch it over to Leanne, who is going to talk to us just briefly about her experience and does it work. Okay, next slide. So the purpose of this slide, I just wanted to show that Hemlibra is not brand new. It has been around for a number of years. In 2016 is when it was started in Europe and Japan. And in 2017, it was approved by the FDA in the US from a safety perspective for all patients with hemophilia. Health Canada approved it shortly after that from a safety perspective. So Health Canada doesn't decide what drugs are paid for and which ones are available and whatnot, but they decide from a safety perspective, is it safe? And so they did approve it for all, hemophilia patients with or without inhibitors. After that, Canadian Blood Services, those are the people who are responsible for making those decisions and for essentially covering the cost of the Hemlibra. They work with a group called CADETH, and they do a cost effectiveness analysis. So they look at how much hemophilia is costing us currently and how much they can anticipate that it would cost on Hemlibra. So at that time in 2018, Hemlibra was approved for patients with inhibitors because from a cost perspective, it was worth doing that. So any patient with an inhibitor and hemophilia A qualified. In 2020, that's a long wait from 2018 to 2020, but CBS said, yes, we're on board with doing it, but we're going to leave the final decision up to the ministers of health. And so big day for me on September 9th was when CBS announced that Hemlibra is now available to all patients with severe hemophilia A. I know that there are also patients with moderate hemophilia A who are on prophylaxis, and those patients aren't currently automatically approved, but I have spoken to a number of people and we can certainly make a case for that. So I don't anticipate that that down the line we'll have issues with that, but obviously I can't make any promises there. So we'll go to the next slide.
So this is kind of the boring sciencey part of Hemlibra and kind of what it makes it different and what makes it kind of so cool. So in the past, all of the treatments, all factor replacement, whether it was recombinant or plasma derived or extended half-life, really you were just replacing what the body wasn't making. So you were just straight up replacing the factor VIII. So Hemlibra is working, it does the same job, but it does it in a totally different way. So instead of replacing factor VIII, what it is it's called a monoclonal antibody. So it's basically an antibody. So very similar to the antibodies that we make after we get an immunization or after we get a cold or anything like that. But this antibody is trained, basically it has two arms and one grabs factor IX and one grabs factor X, and it brings them together to kind of continue on the coagulation pathway so that you can make a blood clot. So basically what it's doing, it totally is unlike factor VIII, so it doesn't look like factor VIII at all, but is completely mimicking the role of factor VIII. We use monoclonal antibodies all over medicine, so very common in cancer, very common by our rheumatologists who treat lupus and rheumatoid arthritis. So this isn't kind of new technology, it's just newer in the sense of it's being applied to hemophilia. It started off primarily on patients with inhibitors. So patients with inhibitors have their own antibodies that destroy the factor VIII that we give them. And so the reason why Hemlibra was such a game changer for these patients with inhibitors was that because the molecule looks completely different, those antibodies that the patients had already produced against standard factor VIII, couldn't touch the Hemlibra. So then Hemlibra could still do the job, still help these patients form a blood clot without being interfered with the inhibitors that the patient has developed. So the kind of takeaway from this slide is It's a totally different molecule, so it is not just standard factor replacement, but basically it's mimicking the role in our body that factor VIII would otherwise be doing. Next slide. I think I said a lot of this, but there's a fancy quick, if you hit forward again, there's a little graph that goes super quickly, a little cartoon. Well, oh, it didn't work. Oh, there it goes. So that's your activated factor VIII. So it's kind of this, there's the Hemlibra doing the job. And then the second part of it is basically, that's what factor VIII does. So basically it does the same job as factor VIII, but looks totally different. So that means when we measure your factor levels, we're not increasing your factor level. So your factor VIII is still going to be whatever it is at your baseline. But it won't change those measurements. Right now, Hemlibra, it's hard to kind of quantify how protected you would be against bleeding, but research is kind of saying, research and also our clinical experience shows that people on Hemlibra are protected about as much as a person with mild hemophilia. So most of our patients, and I think Heather will talk about our personal clinic experience, have greatly reduced spontaneous bleeds, but are still getting kind of minor bleeds with injuries. So basically what we're telling families is basically once you're on Hemlibra, we're kind of, we've converted you a bit to a mild hemophilia. So what we are definitely seeing, and I think Heather will speak to this, is very much a change in kind of how we think about the disease. So a lot of our patients actually have more bruising, but again, less spontaneous, serious bleeding. And the bruising that they are getting is healing up on its own. Next slide. So how it works. So basically, we need to get the levels of Hemlibra up to a certain point in your body. And so how we do this is when we start the medication, we give 3 doses, 3 slightly higher doses weekly for 4 weeks. And we call those the loading doses. So if you look at the graph at the bottom, that's kind of bringing the graph, your level of Hemlibra steeply up to kind of the level where it's going to protect you. And then we start what's called maintenance dosing. So dosing that's going to keep you at that level, and you kind of like the plateau that you see in the graph down below. There's different dosing regimens. So you can be given weekly or every 2 weeks. There is some evidence for every 4 weeks, but this is more in adult patients. It's not really been proven in kids under 12. And I guess the biggest concern is the more you space out the dosing, the bigger dose. So you're giving kind of 4 times the dose if you give it every 4 weeks. And so the volume of the medication that you need to inject into your tissues is pretty high. And so that can be a bit much for our young patients. So our plan, at least in Edmonton moving forward, would be after the loading dose, either going to once weekly or once every 2 weeks, depending on multiple factors in terms of vial size and whatnot. And I think next slide. So side effects, again, these are kind of the ones that they talk about with the product monograph. So this is what the drug company will tell you. To be very honest, all we've seen really is some, with the larger doses, the patients report some stinging when the medication's being administered. And certainly Heather has Heather has some good techniques in terms of kind of mitigate that stinging. So that's mostly an issue with the once weekly loading doses, so those first 4 doses. We've had a few patients who have developed a little bit of redness around the injection site. Other common side effects, fever, joint pain, muscle aches, diarrhea. I don't think we have seen in any of our patients up here in Edmonton, but they are listed, so you need to know about them. The uncommon side effects, so early trials, so this was with adults who had inhibitors who were on a bypassing agent, a specific bypassing agent called FIBA. We don't typically use it in our inhibitor patients. We use a different bypassing agent. But what they were finding is when these adults were on longer term high doses of the FIBA as well as the Hemlibra, there were some adults that developed some serious blood clots. In the main pediatric, so the main childhood study, they had no incidence of blood clots. The other big thing that people are always worried about is the risk of developing inhibitors against this medication. So is there a risk of developing antibodies that would then make the Hemlibra not work? Again, data is a little bit limited in terms of we have less data in the literature as compared to the standard factor products. But based on the literature, they're finding that about 5% of patients are developing antibodies. Of these 5%, not all of them are affecting the drug level. So they're not all decreasing the effectiveness of the medication. And most of them are what we call transient. So you develop an antibody and it goes away on its own over time. So of about 700 patients from the preliminary studies, they only had 2 patients that came off the medication because it no longer worked because of the development of inhibitors. So a rare concern, but certainly less of an issue as compared to the standard factor products that we have traditionally been using. Next slide.
And so one of the things that people really like to talk about with Hemlibra is the way that we deliver it, because it's very different from what we're used to with the factor. Hemlibra is given as a subcutaneous injection, which means that you use a very short, small needle to put it into the fatty tissue just underneath the skin. So it's a shot, but it's more like an insulin injection than it is like a vaccine. So it's very small needle. And it doesn't go into the vein like we're used to with factor, which means that we have a lot more sites that we can use to get the medication delivered. Anywhere where you sort of have excess skin, anywhere you can pinch an inch is an appropriate spot to give Hemlibra. And it makes it easier to rotate sites because you have so many more options, which we would recommend changing sites. And so in terms of those supplies, those are different supplies than we use for factor. And it's great that the company Roche supplies these supplies through a program called Easy Start, which you can be registered for when you start on Hemlibra, and then you can be in contact with to have those supplies delivered to your home. Next slide, please. And then Dr. Stammers talked a little bit about the scheduling of the dosing, and it is sort of dependent on the patient, on the clinic, and on the dose itself. It has been studied to be given after the first 4 loading doses, which are weekly, and the bigger doses. Then you can go to a maintenance dose, which can be weekly or every 2 weeks, or in older over 12 or adults every 4 weeks. In Calgary so far, we've only done it weekly, but it certainly has been proven effective on a 2 weekly dose. Very different from factor. The dosing is based like a medication. So it is based on weight, and it will change over time. And when you give it, you give the exact dose. You don't give the entire vial. And so that's just one thing that has to be learned, is how to draw up to the exact right dose for you or your child. And sometimes we have to mix between 2 vials, which is something we can do if we need to. And next slide, please.
Thanks, Nikki. So treatment of bleeds. So important to remember, Hemlibra is not a cure for hemophilia. We don't have one of those yet. But patients with severe hemophilia will still probably have some bleeds in their lifetime. And a lot of that will be from accidents. You still will need to get factor VIII pre-op. So if your kids, need teeth pulled, wisdom teeth is a bigger surgery than kind of just pulling baby teeth, or appendectomy, or just any kind of surgery. We are still going to use factor VIII for that, for if you do have a bleeds. So we're going to advise families to keep enough factor in the home for 2 major bleeds. The other piece that we didn't really include is we will, for about 2 weeks, bridge your factor VIII. So you'll still continue giving factor VIII until after your second loading dose. And again, we will go through all of this if and when you guys choose to make the switch. But so you'll keep 2 weeks, you'll have 2 weeks at home plus enough factor for 2 major bleeds. We still will use a lot of tranexamic acid for nosebleeds, mouth bleeds, minor dental procedures. If your child had an IVAD, we will plan to take that out. And so one of the kind of downsides of this is not having a port. And if you don't have a port and you're not infusing at home, then a bleed means that you do need to go to the emergency room for a treatment. Having said that, we don't expect that that your sons will have much for bleeding. So, but it is one thing to keep in mind. And if your child does have a bleed, you can't give Hemlibra. It's not going to work. Only factor VIII will work to stop a bleed. So Hemlibra is more for preventing. Factor VIII is more for treating and preventing, but quite different. Next slide. So in terms of monitoring, you still need to come see us minimum once a year. And there are a few reasons for that. There's some legal aspects to it, but we also want to just make sure that we're assessing the dose. We'll still have physio coming to our clinics to assess joints and make sure that there's no issues there. And just to make sure that the emicizumab is working. Having said that, we right now are doing some blood work in clinics, and your blood work is not going to look the same when you're on Hemlibra. It needs some special testing. So in normal hemophilia treatment, we're quite focused on numbers and what your factor level is going to get to. And with emicizumab, it's a lot more of an observation. And so how we know it's working is if there are no bleeds. And yeah, I put there only certain labs are able to measure factor levels and Hemlibra levels. Oh, I think we skipped over a few. Yeah, next one. Perfect. So this is just a comparison between Hemlibra and factor VIII. So as we know, Hemlibra is given as a subcutaneous injection, whereas factor VIII was IV or via the IVAD. One of the biggest differences is that the half-life for Hemlibra is 30 days. So what that means is that if you get Hemlibra on the 1st of the month and you don't get it again until you forget or whatever happens, if you don't take it again that whole month, you still have some in your system at the end of the 30 days. Whereas with factor VIII, it goes through your body quite quickly. 8 to 12 hours would be a fairly decent half-life, but 30 days is what you have for Hemlibra. Testing the levels in the blood isn't as easy. As I said, it requires special lab tests. But in factor VIII, we are able to measure factor VIII levels, inhibitor levels. Those are all quite easy to monitor. Hemlibra, again, will not treat a bleed. If one occurs, you'll need to go to the ER unless you know how to do home infusions or peripheral infusions. Whereas factor VIII is given to prevent and right away to treat bleeds when they occur. Hemlibra, all of your supplies come in a little shoebox that would be 3 months worth of supplies. And it comes with the needles and the syringes, alcohol swabs, everything that you need in there comes from Easy Start. And factor VIII, the supplies come with the product. So in terms of ordering, that doesn't change. You're still going to call us when you have about 2 weeks left of your product. We do the ordering the same, and you'd still pick up from the same hospital or setting that you pick up from. It should be stored in the fridge, but again, these vials are tiny, so you will have room. You won't have to get an extra fridge for this one, like some people have with factor VIII. Next slide. So right now we have about 12 patients on Hemlibra, and I've asked all of them to give me the good, the bad, and the ugly. So these are just a couple of quotes from some patients and some parents that we've had that I thought would resonate a little bit. So this one's from a patient 10 years old, that the first 4 loading doses do sting a little bit more than with factor, but they get used to it. It doesn't bother them anymore. And in fact, they actually can have a lot more control by being the ones to push down on the plunger. So the mom or dad might do the poke, but the kids as young as, I would say that even probably 6-year-olds could probably participate in giving the dose. So it does give them a little bit more control. Some of the things we've heard from a few parents is that they did notice a few more nosebleeds and a bit more bruising, and that's why you use tranexamic acid. It's shifting the mindset a little bit. So we're learning to unlearn the treat right away approach. That's what we've ingrained in all of our patients and families, is if there's an injury, treat right away. With Hemlibra, it's going to be a little bit more of a watch and wait. If your child rolls their ankle, they might have to stay off their ankle for 4 or 5 days, just like any of us would if we rolled our ankle and sprained it. Whereas in the past, when kids with hemophilia do that, you give them a dose of factor VIII, and they're pretty good to go within a day or two. So again, like I said, more control of hemophilia because I don't have to wait for my parents to do the infusions. A lot of kids were really wanting to get their IVAD ports out, so that was a big thing. Parents feeling more comfortable to send their kids to sleepovers, and one family commented that it seemed too good to be true. It was a really hard adjustment in the beginning, but now they can focus on other things. And this morning I got my favorite comment. Next slide. I already cried when I got this one, but oh, never mind. That's not the next one. Can you go to the second last one, Sarah, please? Just since we're there. Oh, it's not on that one. Okay, I'll get it for you guys. Sorry, Leanne. I thought Jace's note was in here. I'm gonna get it though when we're doing some questions. Okay, next slide. So what's next? So the Easy Start enrollment, that's all done by the clinic. Families need to sign the consent. They will ship all the necessary supplies to your home. It's a good idea to just start counting your supply of factor VIII. You'll need about 2 weeks to do that bridging for the first 2 loading doses, and then keep a couple extra doses at home in case of bleeds. I think it's really important to start talking to the boys. If you guys choose to make this switch, it's important to talk to them about it beforehand. And it's not, none of us can really speak to how it feels. And so even though we say, oh, it's a tiny needle and it just goes into the fatty tissue, it does feel different. And so I think we really have to appreciate that treatment is going to look different, and the longer we prepare these guys for it, the better. It is weight-based dosing, so get a recent weight. That can also be done in clinic. CBDR needs to be up and running and people recording their treatments in there. The RNs will have to make some tweaks on our end. And the Hemophilia Treatment Center, so your clinics will make plans for IVAD removal, and you'll need to make sure that you have enough supplies at home that you can access and flush the IVAD a minimum of once a month. Roche has provided there's a link at the bottom there to the injection video. We would do all of this teaching in person again, but that it is a very good video to watch and to just kind of see how simple the process is. Okay, next. Okay, so I'm going to leave this to Leanne while I find the note that I wanted to show you guys. And so I'm going to leave it up to you, Leanne, to take it away.
Thanks, Heather. Hey, everybody. Thanks for having me tonight. This is one of my favorite topics lately, so I'm pretty happy to be talking about it. And I'm really happy that other people are going to have the opportunity to use this medication if you so decide for your child, or even for yourself if you're a male with hemophilia. Does it work for Jace? 100%. Jace started on Hemlibra back in 2018 when he had a really, really major bleed that we just couldn't get under control. So we were lucky enough to be granted compassionate care to get on it. So he was, I believe, the second child in Canada to be granted access to Hemlibra. And Heather gave him his first dose in the hospital, and I believe we were released the next day. It had an immediate effect on him. So what's changed? Couple things. So no hospital visits. The only reason we go to the hospital now is because Jace is a boy and he runs into things. We've had to go there for stitches, I believe, twice. Other than that, nothing hemophilia related. Even when he got the stitches, we didn't give any extra factor. He clotted on his own because of his Hemlibra dose. And it was pretty easy. So it was just like bringing my other son, Kale, to the hospital and getting him stitches. There was no real difference in that visit. So no extra factor for Jace for a lot of things. Granted, this might not happen for each patient, but for Jace, he's also had some surgeries. Since being on Hemlibra, he's had a couple of baby teeth extracted, I believe an adult tooth extracted as well. And as Heather mentioned, his port removal surgery. And in all of those, he never did need extra factor doses in there. We always had it on hand in the OR or whatever, just in case, but we never did have to administer any. He just clotted on his own, which was quite miraculous compared to his previous port surgeries where we were there for, I think, 8 days. Jace had to stay in there because he has an inhibitor as well, so he takes a little bit longer to clot. Infusion ease and frequency. Again, Jace had a portacast, so an IVAD, probably most of his whole life, actually. I can't even remember what age he had it. He had it for so long. So Jace was really used to getting his needles via his IVAD, and he was comfortable with that. We never really had an issue with that. So that was one of Jace's biggest anxieties when we were switching over to Hemlibra, was getting a needle in his arm. So we kind of got him through that, and Heather helped out with that. We went into the hospital the first few times because, of course, we were training on how to give that dose and how to administer that. But he got over it pretty quickly. We used distractions, like he watched YouTube while we were doing it, and we like to bribe our children, so we gave him candy after, whatever works. So that worked well for him, and he got over it pretty quickly. And in fact, he's helped a few other kids that have started on Hemlibra. He did a little video that he agreed that I could record him getting his infusions, and we've since kind of sent that to a few kiddos that had some anxieties on the transition, and I think it helped out quite a bit. So I'm open to helping out if anybody does decide to go on that route. Feel free to reach out to me. What else? Activities and inclusion. That's a big guy. So Jace loves sports. Jace loves hockey. He had a Make-A-Wish, went to see Marc-Andre Fleury, like he's obsessed with hockey. His older brother plays hockey, his dad plays hockey. So Jace could never play hockey, of course, but he always helped out my husband coaching my older son's team, and that's how we kind of got him included. Well, when he started on Hemlibra, no, he's not on a hockey team. We still didn't say, hey, it's okay to go play contact sports, but he literally plays every single other sport out there. Soccer, he's on a basketball team now. He joins the running club. In fact, he almost joins every club that's out there because he can. And he can commit to it now. Jace likes to go all in, and it really bothered him when he would join a club and then have to miss a practice. His perspective of that was that he was letting his team down. So for him, getting the confidence and knowing that he's going to be okay playing these sports and won't get injured, I think has just improved his confidence greatly. So yeah, my kid's a joiner, which is nice to see. Confidence in general, gets better grades now because he's at school more. He can join in on projects, when they have to do presentations when they're a little bit older together and do some group work. He's actually there to be involved and join in with it. So it's a big deal for him. His body is strong and healthy now. Jace was in a wheelchair a lot or on crutches quite a bit of his early life. So he lost a lot of muscle mass, muscle tissue. And he'd go as soon as he was off crutches and try to get it back, and he would, but then another bleed would eventually occur. So Jace is crazy strong now. So it was interesting. One of the biggest things we noticed actually after he was on Hemlibra is he'd say, "Oh, Mom, my abs are so sore. My arm is so sore." Well, it was muscles. His abs were sore because he just ran like a marathon or did the monkey bars 300 times. So it was interesting trying to figure out what was a bleed versus what was just regular muscle soreness from him working out and being an active boy. So that was a really interesting transition for our family, trying to figure that out. And we really communicated with Jace on that to try to articulate what he might have thought was a bleed versus what he didn't think. And that was, I'd say, about a year transition trying to figure that out. So he now comes to me. He came to me the other day actually and said, Mom, I think I have a bleed in my ankle. I said, okay, let's put you on crutches for a few days and we'll monitor it. And sure enough, no extra factor, rested it a little bit, didn't go to basketball that, that day or the next 2 days, and it resolved on its own and he was fine. So like Heather said, it's almost like they have normal injuries. They're still going to roll their ankle and need to be on crutches because they're boys and that's what they do. Will they need factor? Maybe, but in Jace's case, he hasn't actually needed any to recover from these injuries that he's had. So it's been nice. What else? Hardest part was transition. For Jace, like I mentioned, it was going from port to poke, getting him over that transition. Took a little bit of time, but I would say probably after about a month of getting his weekly infusions, he gets his injections on Sundays. And to be honest, we have to put it in our calendar or we would completely forget because they're so infrequent now. So every Sunday we go and we give him his little infusion and off we go. And sometimes, yeah, he does feel the burning. I have had that feedback from him as well. I haven't figured out, a pattern as to why, if there's a different technique that we've done to give it that day, but once in a while he will mention like, yeah, oh, this one hurts, Mom. So, but he gets through it. The other thing is waiting for the next bleed and it not coming. That was a huge transition. I think I called Heather like 50 times. I'm like, hey, I don't know what this is. This isn't familiar to me. Like, is it a bleed? She's like, I think it's just normal growth. I think he just ran. Like, so talk to your HTC. They're great getting you through that transition because it's foreign to us. We've been doing this for so long, and you've been like those gentlemen that are, 30 and 40 and 50 years old. They've lived with this their whole life. And when they don't have bleeds come anymore, you kind of think, well, when's the next one going to come? And for Jace, so far it hasn't, and it's been 3 years. It's pretty remarkable. Considering he was a kid that probably was in the hospital or had a bleed. Oh, Heather, I don't know. How often? I have no idea. Once a week? Felt like I was in there?
Yeah, you can see on the left, between the end of March and July, those were all bleeds.
Oh,
So
there you go.
I did count it up. I don't know if I told you this, Leanne, but I counted it up, and in just under a year, he got 701 blood products. So
it's crazy.
So yes, his case is, Jace really did kind of the worst of the worst. Jace had a really bad go for the first couple of years, and so that dramatic of a difference, I don't think, just because a lot of our patients now don't. These are patients without inhibitors, but
exactly, yeah. But still, they have their bleeds too, and they have their spontaneous bleeds, which, like you mentioned, those with Hemlibra, you don't really see the spontaneous bleeds anymore, which is nice. So if they bleed, it's because they've probably done something, fell off their bike or whatever it is. So it's a little bit more predictable, I find, being on Hemlibra for sure. What else? Oh, use my CBDR. That's my tip to you, because you won't remember when they got injured. I go in there and I add whenever Jace has an injury, because forget it. It's that they're so few and far between that you can't remember when it was. So, and then you'll go to your HTC and they'll be like, hey, have you had any injuries? It's like, yeah, I have no idea. So use that tool. It will be very necessary for you to remember things now moving forward. And as it's on your phone, it's super easy to log. So we quite enjoy that. The other thing, remind them they still have hemophilia. We've had to have this conversation with Jace a few times because he sometimes forgets completely that he even has it. So we do talk about bleeds. We do talk about how that felt. We do look at old photos and old videos, to just remind them that, hey, you still do have hemophilia and you still do need to be careful at certain things. So yes, you've been given this opportunity to have a whole new life, essentially. But remember, it's still there and it's still a part of you, and that's an important thing. So it's funny. I think it like resonates with him now. He's actually kind of happy to have Hemlibra. He's happy to have hemophilia now. I think because it's managed and he can still live a full life. It's a totally different story than it was 3 years ago, for sure. Letting go of the port for him was hard. We hung on to ours a little bit longer because Jace is an unpredictable child with medication. So eventually, though, it quit working and we couldn't flush it anymore, because you do have to flush the iPad's ports. I think it was once a month. I don't even remember.
Yeah,
once a month?
A minimum of once a month, yeah.
Okay, so you still have to flush them once a month, even though obviously you're not using it to give them medication, you still have to flush it. So we went to flush, didn't work, out it came. And again, it was a nothing surgery for Jace, got removed. We went home pretty much the next day, so it's quite remarkable.
I don't think you guys, Leanne, I don't think you guys actually stayed overnight.
I don't think we did either.
You didn't, because I remember going home thinking, oh, I sure hope I don't hear anything tomorrow, and I didn't. So
You didn't. We went home. I know, it's crazy. I was just going to mention too, I talked to my uncle, who is now actually over 7 years old, because I wanted his feedback on Hemlibra as well. He started on it on a clinical trial very shortly after Jace did. And he, of course, has inhibitors as well. 7-year-old man, you know, has had a limb removed because of the joint damage in his leg and so forth. And I had to convince him actually to get on this medication because he was so reluctant. And I knew it would work for him. I knew his history, our family history, so I did help him get over that hurdle. But he had 3 things to say based on his feedback too, and he said he's not as achy anymore. Bad joints that were really damaged over the years from bleeds have a lot less pain, if any, some of them, which I thought was quite remarkable, and just less joint pain in general now. So like, it's crazy. It helps all ages. So even those with damaged joints, it seems to be, you know, making the pain less. And maybe it's not, maybe it's in their head, who knows? But if you feel better, I think that's a win too for him. So anyway, I'm pretty happy to hear that from my uncle too. So there's 2 perspectives. Yeah, so that's all from me.
that's great. Thanks so much, Leanne. I think we can just go to questions. Yeah, questions. What have you got for us, Sarah?
Okay, so I just actually have 2 questions so far. Actually, first one's just a quick one for Leanne. Someone's asking how old Jace is now.
Yeah, so he was he was 8 years old when he got, or 7 years old actually, when he got on Hemlibra. So he is now 11.
And the next question, I guess, is for the nurses or Dr. Stammers. If you develop an antibody, can you go back to using factor VIII?
Yes. I don't know, Dr. Stammers, do you have anything to add to that?
No, I mean, that's the beauty of this conversation, is that we're talking about switching patients who don't have inhibitors. So as compared to Jace's situation, Jace really had no good options because he had this inhibitor we couldn't get rid of. But absolutely, if you even if it's not even an inhibitor to emicizumab, but if just lifestyle is not working for you, or the burning is terrible, or at the injections, nothing is forever. So if you decide to switch to Hemlibra, you're not stuck on it. And because your son probably, again, for the sake of this conversation, if there's no inhibitor, you can for sure just go back to a standard factor product.
Okay, and we just had another one come in. Does the numbing cream seem to help with injection site soreness or burning? I guess that's to anyone.
I don't know if Leanne, or I don't mean to put you on the spot, Danica, but I don't know, have you guys been using the numbing cream?
We don't, but again, with Jace, we never did for his port or anything. So for us, it just wasn't something we used.
Yeah. And Danica, do you have anything to add? Oh, we can't hear.
She's on the line.
Yeah,
she's talking. We can see her talking.
That's okay. So the numbing cream would essentially ideally help with the needle going in, but not necessarily with the stinging, because the numbing cream really just numbs kind of the top layer of your skin. So having said that, there are a lot of kids that just need the cream and it helps. And so I certainly wouldn't be opposed to using it. There's nothing wrong with using it. Medically, physiologically, I don't know that it would help, but if it helps in the minds of these kids, then we would use it.
And Danica is responding now just by text, and she's saying we do use the numbing cream with her son. It does not help with the sting, but it does help with the poke.
Okay, good. Thanks, Danica and Nathan. Any other questions?
I've got another. Yeah. What is the outlook for moderates? Is it looking more to be based on studies or cost of treatment?
Dr. Stammers, do you have anything? I have
I
some
mean, I
thoughts.
think it's more our opinions at this point. I don't think we know because it's really kind of out of our hands. We certainly have some moderates that um, bleed just as much as severe hemophiliacs, and so we definitely have some moderates who are on routine prophylaxis. So if the argument, I think Heather's going to say the same thing. If the argument is that there is cost effectiveness to use it in someone with severe hemophilia who's on prophylaxis, then those moderates who are on it, who are on regular prophylaxis, I think there's a case to get them treated as well. The quote unquote good moderate, so the patients who are sitting at about 4%, I think who aren't requiring regular prophylaxis, I think the argument would be a little bit harder there. But I think certainly the moderates who are have shown us that they are bleeders, I think we can certainly make an argument for it.
And I will.
Yeah.
Um,
Heather's really good at writing very persuasive paperwork.
Well, I see the benefit of it, and to be honest, the cost between a patient with 1% factor 8 versus less than 1% factor 8, if you're on prophylaxis, the cost is exactly the same. Our moderate patients bleed just as much as some of our severe patients, and so what I've been told is that we would need to kind of apply on those patients' behalf, which we absolutely would. And so my prediction would be that we would probably wait a month or two once things get rolling. I'm told that by the end of October, I should get the application forms, the updated application forms from Canadian Blood Services. So it's not something we can switch immediately. We will try to do it as kind of organized as we can. But for the moderates, yeah, I mean, I would absolutely apply on their behalf. I think I probably just wouldn't do it on day one. I would get a few more applications in before those ones. But I did invite a couple families here with moderate hemophilia because of this, because I think that that we will do anything that we can to get them on.
I think certainly, yeah, Heather and I are kind of aligned, and I think certainly we'll advocate on behalf of those moderate patients that we think would benefit from it.
One thing to mention with that too, which I didn't actually even know this was a thing until we got on Hemlibra or Emicizumab, whatever it's called nowadays, I don't even know.
Both.
Both, yeah. So
every drug needs two names.
Every drug needs two names, and they're all difficult to say. Is the prevention in joint damage. So when you're doing prophylaxis, you're treating when you have a bleed, so that joint or muscle has started bleeding. So damage has started essentially. Hence, we treat with prophy immediately to try to fix that. With Hemlibra or Emicizumab, you're preventing that from even starting. So you're kind of getting ahead of it. So that was a big seller for me because Jace had so much damage that seems to have all rectified itself, which is shocking, probably because he's young, thank God. But so that's one of the pros for us for changing too, was preventative rather than treating when there already is a bleed, just to keep those joints healthy.
Yeah. Next question coming in. If we choose to go ahead with Hemlibra, do we contact the clinic, or is the clinic contacting everyone on this call?
I won't be calling everybody, and I'm certainly not going to volunteer Nikki to call all of her patients. I do want to know which patients are interested. Absolutely. We haven't totally decided, and part of it is because of COVID, if we will switch patients when they come in for their annual appointment. The first dose does need to be given in the hospital with just a short, we haven't even decided this, but a observation period afterwards, just to make sure that there's no reaction. So definitely let us know. For those of you who are in my clinic, I'll tell Lynette to, the phone might be
Expect
ringing
phone calls.
tomorrow. And it would be helpful if you included a weight in there, just because I'm trying to give the blood bank some heads up as to what vial sizes we're going to need, so that once we hit go, there's no stopping. So yes, I do want to know if my patients or our patients are interested or not. It doesn't need to be a decision that is made immediately. We can talk more about it at the annual clinics, but we haven't kind of, so far, all the 12 patients we've put on it, everyone has been different. It's been different situations, but yeah, let us know. And once kind of CBS gives us the go ahead, then we will certainly start making those plans.
And I think, I don't want to, again, speak for Calgary. I think just don't expect everybody, all of our patients, to switch on the same day. It's going to be a bit of a slower, controlled rollout. We in Edmonton only have Heather, and Calgary only has Nikki, and we don't want to scare them away. So if we do have a lot of interest, just be patient, and we will get everybody switched who wants to get switched over a certain time frame. Undisclosed time frame.
The other thing too is, if the hospital says no more in-person appointments, then that delays everything as well, and they have done that. And we also, another big point I want to hit home is that we're not prepared to waste factors. So if we plan to switch you sometime in December, then when you call to order product, then I'll probably just order you a month or two. So that could be another time to let us know that you're interested, because we'll schedule it around when you're running low on factor, because I really don't want any to go to waste if we can.
Yeah, and I think Calgary will be very similar. I think for the most part, we've just started the discussions with the clinic visits or phone calls that have come in. There's definitely some patients that need to be prioritized to go first. And so supply may be an issue, and also clinic time, and also COVID rules. But yeah, I mean, we're, really hoping that in sort of 2 to 6 months, we can get everybody switched over who wants to switch right away. And if you don't want to switch right away, that's fine too.
Yep.
But it's just going to be a bit of a process.
There's a lot of paperwork for the nurses to fill out. We have to apply, we have to get a contract, we have to renew it every year. So I'm hoping that the forms come out soon, so that we can at least start filling them in. But I don't know where I was going with that. Yeah, it's coming. We'll do it.
Next question is about the application process for the Hemlibra that you keep bringing up. Is there a chance that patients get denied the medication?
Right. Well, based on that statement that was in the first slide, if you have hemophilia A, and it's the severe form less than 1%, then there should be no reason why you would get denied. That's the exact criteria that they gave us. So with all the families on the call today, the moderate ones, we're going to be just a little bit more strategic with when we put that application in, if that's of interest. But yeah, it's yeah, we will get it going when we can, and go from there.
Yeah, I don't anticipate there being any problems with denial at all. It's just more of a step that we need to do to register and get the product.
Yeah, I guess the only part we don't control is how fast they approve those applications. Yeah. I mean, I've had some come back in 24 hours, and I've had some take 2 weeks. It just seems to be a bit random sometimes. So yeah, that might be a piece that we don't have control over.
Yeah.
Is there a suggested minimum age?
No.
No.
So I'd have to look at the main pediatric trial. I think officially went to as low as 2 years, if I remember correctly. Don't quote me on that. But there's a lot of a lot of centers have published their own kind of experience with it. And I just shared with the other hematologists in our hematology team here today, there was one center that used it in a patient that was 2 months old with inhibitors. So I don't think we're not anticipating to start a newborn with severe hemophilia without inhibitors on the medication, just because newborns typically don't have problems. But at this point, I don't think there is a lower age. I think our youngest patient is right around 1 year old.
Yeah. So we would start them now on Hemlibra, which is, it just blows my mind. But we would start them on Hemlibra before factor VIII, around the same time that we would have started them on factor VIII, which is, you know, give or take around a year of age.
Next question, will this drug interrupt the patient's immunity to viruses and other illnesses?
I don't anticipate that being a problem. That's a good question. I can't see that it would. Certainly during the studies, they didn't comment on kids getting sicker or having more viral illnesses as compared to other non-hemophilia patients. I can't see that it would interfere with vaccines either, because you're not actually influencing the immune system. You're giving kind of a pre-made antibody. So this is the end product an antibody is the end product of your immune system. So it really shouldn't have any impact. That's not specifically been studied, but again, we have used these monoclonal antibodies that are targeting other molecules in the body for different diseases, and they've not had any long-term impact on immune system.
The last question I have, and I guess it could be for the Edmonton clinic, but also for the Calgary clinic as well. Have any of the 12 patients in the clinic been neutral or less than happy with making the switch?
No, no, nobody has, and that's again why I ask for the good, the bad, and the ugly, because when we present this information, it looks very positive, and it is very positive. And so currently, I think the bruises were really bothersome for one mom, but she said, you know what, I looked at the bruise the next day and it's like I could see it healing in front of my eyes. And so no, nobody has regretted at all. And I don't know, Nikki, if you've had
we've got half a dozen in Calgary, and I was thinking when you were giving some of the quotes from your patients, I mean, I have one family that the dad just says it's life-changing. He says, you know, life used to be all about hemophilia, and now it's something that we just deal with once a week and we don't have to think about it. And we've had other families that with IV access, you know, just so much trouble with IV access, and this has solved it for them. So for different reasons, but all of the patients, no one has looked back so far.
Yeah.
That's it. I have no other questions coming in.
Okay, well, thank you, Sarah, and to the CHS for allowing us to use your Zoom platform and being a fantastic host. And thank you, everybody, for coming today. I hope to.
There, I did find that quote from Jace. Do you want me to read it as a closing comment? Everybody can leave on it. All right.
Yes.
So I asked Jace if he wanted to come on camera today and speak, and he got a little shy and said no. I said, okay, well, why don't you write what you feel? So this is what Jace wrote. Before, when I didn't have Hemlibra, I wasn't able to play sports or play outside that much because I was on crutches or in a wheelchair. But now I can do everything because I have Hemlibra. Hemlibra changed my life. So pretty big words for an 11-year-old, I thought. So I didn't expect that. I thought I'd get like some random things. So that was pretty nice to see today when he gave you that sheet of paper. So I sent it to Heather and we cried together.
Yes, I thought that I had put it in the presentation here, but yes, and I was hoping that Jace's words would inspire other families to, you know, if they decide to go down this route, I hope that they feel like they can't do everything, but that they can do most things. So.
And one last thing I just wanted to mention, first of all, thank you to Heather, Dr. Stammers, Leanne, and Nikki for being on this call tonight to share all of this wonderful information with us. And I will be sending out the link to that video that was on the presentation, along with the recording of this call, just in case anybody missed anything and wants to catch it again. And if you have any other questions, don't hesitate to reach out to myself or the clinical staff. Thank you.
Great.
Have a good night, everyone.
Everybody. See you
Thanks,
later.
everyone.
Bye-bye.